Good morning, all, and welcome to May 22nd's Med Ed session, Doulas, Primary Care's Most Valuable Untapped Asset. We're super excited about today's session, and I have some really amazing speakers joining us today. My name is Meg Wills, and I will be hosting our session today. This is brought to you by Care Oregon and the Care Oregon Pharmacy Department. So get settled in and welcome to the show. Today's MedEd session has been approved for 1.5 credit hours by the American Academy of Family Physicians and the Oregon Board of Pharmacy. And then the NASW, or National Association of Social Workers, CEU credits are pending, and we anticipate those coming through any day. So at the end of the session, when you receive your evaluation, please go ahead and complete that if you're registered. You will receive that if you are registered for the session. Go ahead and complete that, and that's how you're going to get your credit hours. So for today's agenda, after we wrap up our welcome and housekeeping, we're going to move into a presentation where Dr. Joe Black is going to share some data findings with us on some Care Oregon Medicaid members who have received doula supports and sort of the implications of that. And by about 7:50, we're going to move into Dr. Melissa Cheney's presentation, really about how to optimize and access doulas as part of the clinical care team as a really important resource impacting patient health outcomes ultimately. And then at the very end, around 8:40, we're going to move into our Q&A session. Highly encourage you all to put your questions in the chat as they come to you. We have a subject matter expert on the topic, Christina Clay, who's going to be monitoring the chat and is able to respond to some of those questions as appropriate. And then if there are questions specifically for the speakers that you want asked at the end, Christina will ask those on your behalf. So please pop them in as we get through the session. Our learning objectives for today are to examine recent data findings regarding Care Oregon Medicaid members who have received doula support, understand how doulas can improve birth outcomes for our most underserved Oregonians, and identify best practices for effective integration of doulas into clinical care teams. I'm going to go ahead now and pass the mic to Dr. Leona Okeefe, who is a medical director at Care Oregon. Welcome, Leona.
Thanks, Meg. Good morning, everyone. Leona Okeefe. I'm a family medicine physician and practice full spectrum. So that means I also practiced obstetrics care in the US, metropolitan Los Angeles area, overseas in rural Nepal, as well as in rural Southern Oregon. In my role as medical director at Care Oregon, I get to hold relationships in our medical community to collaborate on improvements to our healthcare system, specifically to increase access to high quality care for everyone, while also improving the lives of our healthcare professionals. And since joining Jackson Care Connect in Care Oregon, I've been able to help bring more focus to our perinatal and early childhood populations, along with Meg and Christina and many other wonderful people at Care Oregon. So it has been a joy to do that. And from the team, I have learned more about the benefits of partnering with doulas, and in particular, the positive impacts that they can have on closing health inequities. So I am really excited to support today's learning. Maybe you're already partnering with doulas, maybe you are a doula, or maybe you've never even met a doula. Regardless of your situation, we really do encourage you as you listen today to think of something tangible that you can do in your current role to impact perinatal care, particularly thinking about partnerships with doulas. As Meg said, put any questions or comments that you have in that Q&A section. If you're thinking of tangible things you can do, put them in there. We'd love to hear what's coming to mind for you. So I get to introduce our first speaker, Joe Black. He is a data science analyst at Care Oregon, and he focuses on Medicaid claims, population health measures, and program evaluation. His background is in applied microeconomics, and he holds a PhD from the University of Oregon. Joe has been an amazing addition to our Care Oregon team. So Joe, welcome, and I pass it on to you.
Thank you so much, Leona. So I'm going to begin by telling you a little bit about what we have learned about the way that Care Oregon members have been using doula support. And I need to apologize to Missy because my very first slide is going to undercut the title of her talk. So this is primary care's most untapped asset. It has become less untapped lately. So each dot here in this plot shows you the rate or the percentage of births through Care Oregon that had doula support. And up until about 2022, that rate was extremely low. And just in the past few years, it has exploded from 1 or 2% to now we are approaching 15%. And the big driver behind that is the increasing availability of doulas to our population. So who is it who has been using these doulas as that utilization has exploded lately? So this is a breakout by race and ethnicity. So I'm just looking since 2023. So really since that explosion started among the Care Oregon population. And just to sort of explain what you're looking at with these bar plots, I've got two numbers in each bar. I've got a percent and I've got an N. So if you take a look at that first one, other race or ethnicity, that's about 16% of 88 total births in that time frame in the other race or ethnicity category were doula supported. So that's the highest proportion when you break it out by race, and then Black or African American, not provided, Hispanic and Latinx, and on down. So this doulas have been more widely used by Care Oregon members of color. We can also break this out by language, and we have got a ton of languages, a ton of different language speakers at Care Oregon. And so I have given you just the top 3 plotted, and I have included all of them listed out in the footnote there. So disproportionately Spanish speakers receiving doula utilization at Care Oregon. And then another way to break out this population of folks who are using doulas is by their number of chronic conditions. And so I just broke it out by 0, 1, 2 to 3 I grouped together, and then 4 or more I grouped all of those together. And doing it by the same way, what's the fraction of each of these groups that is using using a doula when they give birth? You can see it's in this nice stair-step shape. So the more chronic conditions someone has, the more likely they are to use a doula. And across these different breakouts, what I think we're seeing again and again is across categories of medical and social vulnerability. The more vulnerable you are, the more likely you are to use a doula. So the other thing we took a look at is outcomes for folks who use doulas versus folks who do not. And the first one, and there's been quite a bit of research on this elsewhere, is on C-section deliveries. So if you use a doula, are you more or less likely to have a C-section delivery? And the answer is you're quite a bit less likely. I've got 2 pairs of bars here. I'm going to give you some orientation to this graph before I say much more. So the bottom, the sort of like slightly faded colors there, show the unadjusted rates. So just count up everyone who used a doula, everyone who didn't, and did they or did they not have a C-section delivery. But I've just told you that these populations differ quite a bit, right, along other dimensions. So we want to control for other characteristics that folks have. And so when we do that, I'm using a logistic regression for lots of other characteristics. Those characteristics are listed in the fine print down there. That gap widens slightly. So we are finding good evidence that doulas are leading to lower rates of cesarean deliveries to the tune of about 7 percentage points lower. We also took a look at postpartum depression screening. And I want to emphasize 2 things about these bars. So once again, I have the bottom 2 bars are the raw rates. Do you or don't you have depression screening after delivery? And then the top is I've added some control variables, not a lot of change in between the 2. If you look at the ratio between the blue bar, no doula, and the orange bar, yes doula, it looks like the orange bar is quite a bit longer. And that is true in terms of, as a proportion, the rate goes up quite a bit. The other way to think about it is in terms of raw rates. So these rates tend to be low in the first place. So we're going from about 4.8% without a doula to about 6.5% with a doula. Is that a huge jump? Is that a small jump? Really depends on how you decide to set your baseline here. So it's about a 1.7 percentage point increase, or you could say it's about a 20% increase. Those are both true. So I will leave it to you how you would like to frame it. But it is a statistically significant increase in the proportion of folks who are getting a postpartum depression screening if they use a doula. And then the last piece is whether or not folks continue to get behavioral health treatment after delivery. And so I have broken this out into 4 groups. This is my most complicated plot, so I'm going to introduce you for a second. So the top 2 bars there, the top 2 lines that are solid, those are both folks who have a behavioral health diagnosis. So orange, again, is there was some doula involvement, and then blue is no doula. And the first thing that should pop out is that the orange line is just much higher than the blue line. So folks who are opting for a doula and have a behavioral health diagnosis are much more likely to be getting behavioral health treatment than folks who don't use a doula but do have a behavioral health diagnosis. So they're already more engaged in behavioral health care. And then as we see the move from this first dot, for the far left dot, 71 and 75 there, that's before pregnancy, what proportion of them have at least one behavioral health visit. They both move upward and sort of in parallel. So as they go into pregnancy, their rates of utilization are going up. That's great. And then where we see the divergence is afterwards. So this postpartum period, we continue to see that upward trend for folks who do have doulas. So they're going into pregnancy, they're getting more behavioral health care. That continues to go up after delivery. If you don't have a doula, you drop back down again. And so that divergence is really where I think the big result, the big finding here is. Down at the bottom, I've got folks who don't have a behavioral health diagnosis. Unsurprisingly, they have much lower rates of behavioral health utilization, and they're just sort of flat there on the bottom. We're not seeing a particular divergence there. So that divergence doesn't occur among folks without a behavioral health diagnosis. It does occur among folks with a behavioral health diagnosis. That strongly implies that doulas are having a causal effect here. And that is me. I will hand it back, I believe, to Leona.
Yeah, thank you, Joe. That was great. So that is an overview of what we are seeing within Care Oregon members who are engaging with doulas during their perinatal care. And so decreased C-section rates, increased postpartum depression screening, and an increase in utilization of behavioral health care postpartum in those who already had a behavioral health diagnosis. This is so important. We know that C-sections are life-saving. And when it's safe, a vaginal delivery has better outcomes for the birthing parent and the baby. And so whenever possible, we want to have a vaginal delivery. So having doula partnership, making that more likely is wonderful. And then we also are learning that really the highest time of morbidity and mortality in pregnancy is in the first year after delivery, mostly due to behavioral health issues. So when partnering with doulas, if we have increased depression screening to identify people who need more help and increase in behavioral health utilization, that can have a direct impact on those negative outcomes that we're trying to prevent. So Joe, thank you for showing us that this is working not only at the national level, but also here at our Care Oregon level. So a reminder, use that Q&A section, put in any questions that you have. We'll address those at the end. If you, as you were listening to Joe, you thought of some tangible things that you can do in your role to impact perinatal care, go ahead and share that with us as well in the Q&A in the chat. And just a reminder, you don't have to directly provide OB care in order to impact OB care. Primary care providers, urgent care, emergency department providers, you all can mention the benefits of doulas anytime you come across someone who's thinking about being pregnant or is already pregnant. And I know for myself, I imagine, wow, if I could have had someone come to my home 4 to 8 times after I delivered my children just to take care of me and my new baby, I would have felt that much more loved and supported. So keep that in mind as we now get to hear from Missy. So I have the pleasure of introducing Melissa Cheney. She is a PhD LDM. LDM stands for Licensed Direct Entry Midwife. And she's a distinguished professor of clinical medical anthropology at Oregon State University. And she's also a community midwife. She co-directs a program called Uplift. This is a research and reproductive equity laboratory at OSU, where she serves as the primary investigator on more than 20 maternal and infant health-related research projects, including the Community Doula Project. She's the author of an ethnography called Born at Home. That was in 2010. She's the co-editor with Robbie Davis Floyd of Birth in 8 Cultures. That was in 2019. And she is the author or co-author of more than 120 peer-reviewed articles that examine the cultural beliefs and clinical outcomes associated with midwife-attended births at home and in birth centers in the United States. In 2019, Dr. Cheney served on the National Academies of Science, Engineering, and Medicine's Birth Settings in America study, and in 2020 was named Eminent Professor by OSU's Honors College. She also received Oregon State University's prestigious Scholarship Impact Award for her work in the International Reproductive Health Laboratory and with the Midwives Alliance of North America Statistics Project. She's the editor-in-chief of the journal Birth, Issues in Perinatal Care. And perhaps most importantly, she's also the mother of a daughter born at home. So clearly we are fortunate to have Dr. Cheney join us and share her expertise. Welcome. I pass it to you.
Thank you so much for a lovely introduction, and I'm so happy to be here. So today we'll talk about doulas as one of primary care's most valuable untapped assets. And I'll start by saying that Dr. Black, you did kind of undermine my presentation, but what I will say is that even with 15% utilization, that means there's a relatively high percentage of people are still not getting access to doulas, so there's room to improve. I do think Care Oregon should be incredibly proud of the work that you have done, because those are incredible utilization rates. And even though access to doulas has theoretically been possible since 2012 for people who qualify for Medicaid, we can see those recent big jumps in people who are actually utilizing that, and that is coming from the kinds of work that Care Oregon and other organizations are doing to make doula care accessible. Okay, so I have no disclosures. So for our learning outcomes today, I'll start by describing some inequities in birth outcomes in the US. I know many of us are familiar with this, but we'll also talk about ways that doulas and other traditional health workers can help improve a range of measures, including inequities that begin at birth. I'll explain some Oregon policies on how traditional health worker doulas work with Medicaid reimbursement, and critically evaluate the Doula Hub model that we use here in Oregon to talk about ways we can enhance access to doulas in our state. So I'll start with this slide that really sets the stage for what we're concerned about. So what you can see in this slide is that as you look across the world, high-income nations are seeing a decline in maternal mortality around the world, and so are low and middle-income countries. What's concerning is that the US is one of the only high-income countries in the world who's actually experiencing a rise in maternal mortality. So while overall, globally, there's been a reduction of about 45% in maternal death over the last several decades, the United States has seen a 136% increase, which means it's slightly more dangerous to give birth in this generation than it was in my grandparents' generation. And so we're concerned that things are moving in the wrong direction. And we also know that the burden of mortality is not equally borne by members of our society. And so what this slide shows is what we're all familiar with, and that is that among Black and Indigenous people in the United States, we see much higher rates of mortality related to pregnancy. And these have been quite tenacious and difficult to shift. The same inequities exist when we look at infant outcomes. And so what you see in these lower, darker blue bars is mortality out to the first 28 days after birth, and then past that out to a year in the lighter blue. And again, we can see that there's a disproportionate burden of death and suffering among Black and Indigenous individuals. This slide also pulls out Native Hawaiian or other Pacific Islanders who are often grouped together with Asian populations to show that there are inequities often within these groups. Okay, and what this shows is a comparison of how the US is doing compared to our peer nations. So what we can see is other countries that have comparable birth rates, looking at their mortality rates. And you can see that even when we pull out just individuals who are identified as white in the United States, our mortality rate is significantly higher than our peer nations. And when we include the totality of the US population, we get an even higher rate at 24.3. And then let's look at this. This is mortality by state. And so you can see that the US as a whole is just about right here in the middle. And as you range to the left, you can see states that are doing better for pregnancy-related mortality, and then to the right, those that are doing worse. And part of what is motivating this is rurality, so the degree to which these states are experiencing maternity care deserts. So we know that in the US today, a little over 5 million individuals live in communities where they have no access to any kind of maternity care. So no midwife, no maternity care hospital, and no obstetrician. When we look at urban areas, we see that the maternal mortality rate as a whole is around 18.2 out of 100,000, and that number goes up to just over 29 out of 100,000 when you look at rural populations. The same trend is true for infant mortality. It's about 6.8 out of 1,000 in urban areas, and in rural areas, you see a 20% increase in mortality. So this is concerning. And the United States is looking for answers, looking for solutions to help improve outcomes that begin at birth. And I think there's a wide recognition that healthy communities and healthy nations begin with healthy births. So start at the beginning and let's think about how we can help every birthing person have the best possible outcome and treat every baby as a sentient being. We want all families to get the best possible start in life. So across our country today, there's an enormous focus on doula care. So in every state in the United States, there's legislation and at some stage of development, either the beginning stages of looking into a needs assessment, or as in the case of Oregon, we've already passed legislation requiring that doulas be able to be reimbursed by Medicaid. And this is coming from an enormous body of research that shows that having a companion, having a non-clinical person who stands alongside you through the process of birth, a continuity of care, that one person who you know will be with you in the prenatal period, at the birth, and into the postpartum period as you're transitioning into a parent, makes a huge difference for families over multiple markers. We also have a sense that that doulas that are culturally and linguistically matched have a particularly high impact. So this means that when you're pregnant and you meet your doula, you have a sense that that doula comes from your community, you have a shared social history, there's some kind of baseline understanding between you as you begin to engage in care, and that level of comfort and support is particularly useful at improving outcomes. So as a result of this literature, we've begun to dig in and kind of ask the questions, what is it about having a constant companion at birth that makes such an enormous difference? For an anthropologist, this is easy to understand. When we know that the origins of poor health are social, we recognize that the interventions we use also need to be social. It's more challenging in the type of medical system that we live in, where we tend to think that solutions are going to come from pharmaceuticals or innovations or more physicians, to think about the role that just being cared for in your pregnancy can make. So what is it about continuous support from a doula? We know that it helps to optimize birth hormones. So there's a whole body of literature that's called the Tend and Befriend literature, and it shows that when women are together during labor, that their levels of oxytocin rise. When women are together during any kind of stressful situation, being together causes our oxytocin levels to rise and to ameliorate some levels of our stress. They're also associated with increased mobility. So people with doulas are more likely to move around, use position changes, walk around with the support of a doula who's encouraging them to do so. And so together, those help decrease perceptions of pain. And here's a really important piece: reduced fear and anxiety. The most common thing that people say about the experience of having a doula is that they were simply less afraid because they knew one person would be alongside them, no matter what happened in terms of shift changes, whether they were connected to the provider, had ever met them before, they knew they'd have that one person by their side, and this increases their confidence. And together, these result in decreased need for medical interventions and decreased need for pain medication. And what's really important about that decreased rate of intervention is this results in higher rates of spontaneous vaginal births. And spontaneous vaginal births are associated with much higher levels of satisfaction in childbirth. And so we want to remember that the World Health Organization has been quite clear in saying that we can't just look at clinical outcomes. We have to also examine psychosocial outcomes, because they're intertwined. The respect that people experience when they're receiving care is tied to their clinical outcomes. They're inextricably linked and they predict one another. And we want people to go into what is arguably one of the most difficult jobs in the world, feeling that they are confident and capable and not approaching childbirth from a position of trauma or victimization. And doulas are a very effective, cost-effective, inexpensive way to go about doing that. So let's look at Oregon in particular. Oregon was the first state in the United States to pass this legislation, allowing traditional health worker doulas to actually have standards for training, to get onto a registry, and then also be able to bill Medicaid. So oftentimes people look at Oregon as an example. So the idea in Oregon is that we'd have these 5 categories of traditional health workers. So community health workers, peer support specialists, peer wellness specialists, health navigators, and doulas, and that they would serve as these intermediaries, helping individuals and communities navigate what can feel like very, very complex health and social systems. And having that one person, again, that stands alongside and helps you sign up for WIC, helps you sign up for the Oregon Health Plan, helps you navigate getting to your appointments, can make the difference between getting early and adequate access to care and sort of opting out of the system, stepping in only when absolutely needed. So showing up in labor in the emergency department, for example, is one of the things that can happen when people have trouble navigating a particular system. So I'm a professor at Oregon State University, and we found that some of our students who were coming from Arabic-speaking countries were actually returning home to receive healthcare because they were so daunted by trying to navigate the U.S. healthcare delivery system. So imagine that you've been socialized into this system, you have English as your first language. It can still be difficult navigating insurance and referrals and specialist care. Imagine if you're trying to do that in a language that you're struggling to hang on to in a system that is completely different than the one you grew up in. And doulas and other community health workers, traditional health workers, can play a huge role in making sure that people are getting access to the care that they need, to the care that they deserve. So in Oregon in 2018, so 6 years after the bill passed that allowed doulas to be reimbursed by Medicaid, there were 6 white, college-educated, monolingual doulas who had found their way onto the traditional health worker registry. And this is because often when you're the first out of the gate to do something, it's more difficult than you had anticipated. And what we could understand from a landscape analysis of doulas who were attempting to get onto the registry is that many of the classes did not exist that were required, so they were having to go to other states to find those classes. It was also very difficult to navigate the paperwork required to get onto the registry, and no one yet had figured out how to bill Medicaid and actually get reimbursed. So in the first 6 years of our legislation, it existed mostly in theory, and in practice, it was really difficult to access. So in 2018, a collaboration between Oregon State University and a nonprofit, birth justice nonprofit called Heart of the Valley, Birth and Beyond, wrote its first grant to IHN CCO, the Intercommunity Health Network Delivery Systems Transformation Program, to try to start a doula program that would serve 3 counties and actually help doulas overcome each of those barriers to being able to provide care. So our goal was to improve maternal and infant health outcomes for pregnant individuals and their families through the provision of culturally matched community doula services. So our goal was to have people caring for people in their own community, caring for people in the language they feel most comfortable speaking. And this quote at the top here describes our motivation. We said, we can't all be created equal if we can't get an equitable start in life. And this is from researcher Michael Liu. So the goals of our initial grant were to recruit, train, and reimburse culturally and socially diverse doulas, We started in 3 counties. We've now expanded to 5. So we serve in Lynn, Benton, Lincoln, and now Marion and Lane counties. So our goal was to train 30 doulas. And we were inundated with requests for training. And so we ended up training 165 doulas. Our goal was to get 10 on the registry. We were able to get 68 on the registry so far. And I think most importantly for this aim of cultural matching, now 40% of the doulas that are on the traditional health worker registry in Oregon come from communities of color or other communities that have been made vulnerable by systems of oppression. So people are able to serve in their own community. So they have connections around growing up in rural communities, being English language learners, having a history or current substance use disorder, or perhaps incarceration. So people are working with and being cared for by people who they recognize as a member of their own community. And we were hoping that what we could do is test to see if this would improve outcomes and reduce some of those health inequities that I showed you on those earlier slides by providing this one-on-one support and advocacy. And our goal of our program was to center communities made vulnerable by systems of oppression. So we thought to ourselves, a lot of times in the United States, the quality of your insurance that you have and your social standing predict the quality of care that you can get. And those with higher quality plans are often getting higher quality care, or at least more choice in their care. So we said, what if we invert that and we center those made vulnerable by systems of oppression and give them the best possible care? What will happen to their outcomes? And after this program has run for 6 years, we've had just over 2,000 referrals, and we have just enough data to say a little bit about how this program is working. And so that's what I'll share with you today. So here are just the beautiful faces of our doulas. They speak 10 languages. Actually, we just added an 11th. We just have 2 doulas that speak American Sign Language who have just joined the program. And so we are generally able to match people to someone from their own community. The other thing that has been really critical to getting doulas out into the community is what we call hub activities. And so in Oregon, one of the ways that we navigate sort of the bureaucracy associated with getting access to doula care is by hiring individuals to work in hubs that navigate some of the bureaucratic processes associated with getting care. So here's what it takes to actually get a doula connected to a client that wants care. So building referrer relationships, and this is one of the ways, as you're thinking about what you can do in your community, refer people to your local doula program. Many of the regions in Oregon right now do have doula hubs that provide services to people who qualify for Medicaid, and making those connections is really important. When we see primary providers telling their patients about the value of doula care, those patients are very likely to reach out and to accept doula care because they value the perspective of their primary care provider. We also have to recruit doulas and train doulas, develop services that allow us to match clients through a referral process. It's also very important to mentor doulas. As soon as doulas go through their didactic training, they're not necessarily feeling comfortable and confident to be able to provide care. And in the state of Oregon, we require that they do 3 practice births, 3 births where they're not compensated, 3 births where they are learning how to provide care, and having a mentor doula in that situation can be really helpful. They're also required to engage in continuing education and quality improvement initiatives, so submit their data to the hub and have their outcomes evaluated. Those are published, presented, and used in knowledge translation to help raise awareness in communities, like events like this that help people understand how doulas are functioning in their communities. Then there's support to get traditional health workers onto the actual registry and get Medicaid credentialing. And this is one of the spots where we see a lot of doulas stopping delivering care, because the traditional health worker application is only in English. It's very comprehensive, and it can be very challenging to navigate. So in our Doula Hub, we employ a full-time person whose job it is to help people navigate getting onto the registry and getting all the credentialing that they need for us to be able to bill Medicaid for them. We also offer reflective supervision, so they engage in peer review and learning from one another. We manage complaints, which are thankfully very infrequent, but I want to mention just a little bit about this. The one area where people often have hesitation about doulas is a social phenomenon that's called doula discord. And doula discord is the fear typically held by primary providers that the doula will somehow interfere with the course of care. So rather than focusing on providing support and supporting the person to make informed decisions, that the doula might be overshaping or over-determining the course of care, or maybe covertly or overtly sometimes encouraging patients to contest recommended care. And this phenomenon is called doula discord. And even though it is measurably very rare occurrence, it is something that a lot of physicians live in fear of and worry about the disruptive components of having a doula present. And so part of working in a system like ours in Oregon that has allowed this type of integration over the last 6 years is being able to manage those complaints and working to ameliorate them. And so sometimes that means reminding doulas about the best way to stay in their own lane, but it also means training the other members of the care team to understand what it is that doulas do and how they can be of benefit. So one of the requirements for training in the state of Oregon is interprofessional communication and collaboration. And that requires all doulas to understand what each member of the care team does. I often think that it would be helpful for everyone to have that training, not just the doulas, because the doulas could be better integrated into some teams if there were a stronger understanding of that. And occasionally there has to be a termination of a contract with the doula. It's actually very rare. I think there's only been one instance in the state of Oregon of a doula continually overstepping, and she has been asked not to serve. Billing, which is the most difficult part of this. We often in our hub talk about timely, accurate reimbursement from Medicaid as a unicorn because it rarely happens. And at any one point, we're grant writing so that what happens is once a doula in the hub provides care and submits the data on the outcomes from the care provided, we pay them right away. If they had to wait 3 to 6 months to get reimbursed by Medicaid, most doulas would not be able to stay in the profession. And so billing within the hub is really critical to continued practice. And we also provide recertification support. But the take-home message from this slide is that there are still many areas of tension where it's very difficult to add a completely new member of a care team into a system that was not designed to include them. And anything that you can do as a provider to mediate that is incredibly helpful. And the primary thing is really making those referrals and sharing with your patients the value of having a doula present. So let's talk a little bit about the outcomes that we have seen in our program. So I've already mentioned these 10 languages, and I want to highlight here that it seems to be that from the perspective of the other members of the care team, one of the most valuable things that doulas bring is the ability to communicate with the client in their preferred language. And so many of the doulas in our program who speak a second or third language have been cross-trained as interpreters, and this is an incredibly valuable service, at least in the regions where we serve. The translation service on the blue telephone is still standard and not preferred by patients. And so when we can have a doula that is cross-trained as an interpreter, this is significant step in the right direction in terms of improving the experience of care for the patient. And it also improves things for the provider who may be struggling to communicate. The other really interesting outcome for our program is the impact that doulas have on breastfeeding. So it was amazing to our team just having someone in the home multiple times after the birth, checking in, weighing the baby, encouraging the birthing person to reach out for lactation support or to call their physician when the weight gain was slow, and just even having someone to look at the latch or to just encourage them that they were doing a good job made such a huge difference. So when we look at a comparison group of Medicaid recipients who do not have doula support, their breastfeeding initiation rates is somewhere between 60 and 70% on average across Oregon. Some hospitals have as low as a 40% initiation rate, but with a doula that is culturally and linguistically matched, there's a 98% initiation rate. When we look at exclusive breastfeeding at 6 weeks postpartum, the comparison group had a rate of somewhere between 25 and 35%, and with a doula, it's 77%. And perhaps most shocking for us was that at 6 weeks postpartum, 6 to 8 weeks postpartum, 96% of the clients in our program who had a doula had some breastfeeding occurring at 6 weeks, which are really remarkable outcomes. With low investment, these doulas are coming to the house 2 to 4 times in the postpartum period and making an enormous difference in longevity of breastfeeding as well as uptake. Some of the other really interesting findings, and these do parallel what we can see in the national literature, is that families who have a doula are much less likely to deliver prematurely. So in our program, we have the comparison group who's getting standard care, which doesn't include doulas, and then the group that is the intervention group that's using doulas. And what we can see is that the preterm birth rate overall is 11%, but when you have a doula, it drops down to 4.9%. We also 9% dropped down to 4.9%. We also then pulled out just communities of color who are at higher risk for preterm birth to analyze our outcomes, and found that for people of color in our program, the preterm birth rate is 11%, and that's largely driven by Black communities that we're serving, Black and Indigenous communities that we're serving. It drops to 2% with the doula, which is really remarkable. And all of that 2% that had been born prematurely were all late preterm, early term. So not 28 weekers, but 33 weekers, 34 weekers, 35 weekers. So huge impact, lots of research out there on why that might be. And when we ask clients, we ask the patients in our program what they think about the impact of doulas. What we hear aligns with one of the leading theories on why preterm birth rates are so high among Black Americans, and that is that the doula ameliorates stress. So the theory is that the chronic stresses of poverty, inequality, racism, inequity produce high levels of cortisol in birthing people. And as we all know, as that cortisol crosses the placenta into the uterus, it is converted into cortisone, which is inert and does not cause an inflammatory response. But when people are overloaded by stress and cortisol reactions, it can't all be converted, and those high levels of cortisol in the uterus cause an inflammatory reaction that is predictive of early birth. And so it could be that one way to prevent preterm birth is providing more love and more care to people, which is something that's pretty hard to prescribe and sort of out of our way of thinking. But the evidence for doulas and midwives mean that this is a fruitful avenue to examine more closely. And then the last little bit of outcomes for the program that I want to talk to you about, really dig into trying to understand what's actually happening in the relationship between doulas and their clients and with the larger care team that may be impacting these outcomes. And so the study that we're working on now, which is a collaboration between Samaritan Hospital and Oregon State University, is looking at the impact of the primary care provider. So when we look at outcomes for doula care, we see, as I talked about a little earlier, just these improved outcomes, lower cesarean birth rates, higher rates of breastfeeding, et cetera. What's actually happening there? And so what we did is we collected data in 2 hospitals, one that has an obstetric model. There are no midwives present in this hospital. And then we had the second hospital has a midwifery-led model of care, which means the midwives do 93% of all the vaginal births, including moderate to high-risk patients. And obstetricians come in for a few of the normal vaginal births, but also are predominantly doing forceps, vacuum extraction, and cesarean births. And so when we look at the cesarean birth rates across those models, what we found is that in the obstetric model, I should also say that this obstetric model hospital, that the institutional culture of this hospital is very anti-doula. They don't want doulas, and they have the doulas sign a form when they come in saying that they promise not to interfere with the physician in any way, and recognize that they'll be asked to leave if their behavior is deemed inappropriate by the physician, which starts the relationship with a sense of perhaps not feeling welcome. In the other hospital that has the midwifery-led model of care, it's the complete inverse of that. This hospital is really dependent on doulas and tries to get a doula to every single person who qualifies for Medicaid so that they have continuous labor support, because the midwives are actually quite busy at this hospital. Both of these hospitals have the same level of risk in terms of the patients they're caring for. The midwifery model has a slightly higher risk because they do VBAC, and they also do vaginal birth after cesarean, and they also do patients with a higher BMI. But in that midwifery model of care driven model, that hospital has a 24% cesarean birth rate with just a midwife. And when you add a doula, it drops to 20%, which is the lowest rate of cesarean birth ever reported for a high-risk Medicaid population in the United States. In the obstetric model, we see 34% without a doula and 36% with a doula, so a slight rise. That difference goes away when you control for some of the other compounding risk factors. But what you can see is that in this model, the potential impact of the doula is dampened by the institutional culture. And so what this reminds us is that doulas are most effective in systems where they are welcome and well integrated, when there are low levels of doula discord. It also shows that there's some really valuable synergisms between midwifery and doula care. And I'll say that when I first presented these findings, some of the midwives said, wait, I'm so worried about this. I'm stressed and concerned about these outcomes because I really don't think I'm providing care that's any different when there's a doula present and when there's not a doula present. And, I said, that's not the way to look about it. The way to look at it is to say that with the combination of care, we can get these really excellent outcomes. And I think it's important to note that in our country, no one is at risk for getting too much love during their pregnancy and their postpartum, right? No one's leaving saying, I was too cared for, right? If anything, it's the opposite, where people are feeling, especially in the postpartum, that they are sort of set adrift and not seen again until the 6-week visit. So more care, more collaboration seems to be the direction to go. And then I just wanted to point out that there have been several cost effectiveness evaluations, and doulas are incredibly cost effective. Midwives are too, but this is looking at doulas. Doulas are highly, highly cost effective. The cost to training doulas is very low, proportional to the impact that they can have on outcomes. And one of the places I've mentioned, multiple places where they can have an obvious financial impact. One is cesareans, one is breastfeeding. The other one that's really interesting to track, and it'd be interesting to look at Care Oregon's numbers, is emergency room visits, ED visits. So when patients have someone they can access 24/7 through their cell phone and check in about things that are actually normal but seem really concerning in the middle of the night, what we see is a decrease in the number of visits to the ED and substantial cost savings there. Okay, so in the time that we have remaining, what I want to do is now just kind of back out of this very close look at one doula program and talk a little bit more about the potential impact for doulas in our country as a whole. And so I want to talk to you about the Birth Settings in America study. And as was mentioned in my introduction, in 2018, I had the privilege of serving on the National Academies of Science, Engineering, and Medicine's Birth Settings in America study. So Congress commissioned NIH to fund this study, and we were charged with answering two urgent questions. One is, how can an evidence-informed maternity care system be designed that allows multiple safe and supportive options for childbearing families? And how can birth outcomes be improved across and within all birth settings? So our group met for a little over a year. There were 16 of us, and we delivered our final report to Congress on February 6th, 2020. We had 12 recommendations that we made to Congress about how we could improve outcomes in the United States. I don't know how many of you remember what was going on February 6th, 2020, but this was the same day. It was Trump's first impeachment trial ended that day, ended in an acquittal, and everyone was waiting for the announcement. We were definitely not the most exciting thing happening that day. And then a few weeks later, we were in lockdown for COVID. And so there's been a lot of conjecture about the degree to which findings from this study have been able to be taken up in the United States. Typically, right after a report like this comes out, it's presented to Congress, and then there's quite a lot of follow-up afterward to make sure that people have access to the information in grand rounds and that it moves forward to impact policy, and that was significantly reduced due to the pandemic. What I wanted to do is just show you, we had 12 recommendations. I wanted to show you the first 3 that were specific to hospital settings. So universal quality improvement initiatives in all settings, piloting evaluations of value-based payment models for all provider types. But the one in orange there is really critical. Provide greater access to currently underutilized non-surgical maternity care services. So one of our findings was that the U.S. was over-reliant compared to our peer nations on surgical and pharmaceutical interventions, and that they were underutilizing non-surgical maternity care services, such as vaginal birth after cesarean, doulas, and midwives. Right after the National Academy's report was presented, not right after, it was 6 months later, the Centers for Medicare and Medicaid Services put out a call or request for information from experts around the country on what to do about rural healthcare problems. So looking at maternity care deserts in particular. So I'll say that when you're serving on the National Academies, it's a very structured process that you move through. And we are definitely discouraged from editorializing. We spend a lot of time really tying our findings to the research, and the final report is a consensus report. So we have to navigate each one of the conclusions until we come to full consensus across a 16 very diverse specialty group of researchers. After the National Academy's report came out and this call for information happened, a group of us got together, about half of us from our original team got together and thought, there are a lot of findings from this Birth Settings in America report that would help to answer the question, what do we do about inability to access care in rural communities, and specifically in relationship to those underutilized non-surgical approaches. So a group of us came together to respond to this request for information, and the maternal health experts that responded are listed over here on the right. And like I said, this is about half of our team. Later, the other half of our team said that they would have wanted to participate, but they were too busy managing COVID to participate in our working groups. And every major birth equity, birth justice, and midwifery and doula organization in the U.S. Signed on to the request for information after we made it public. So I want to tell you a little bit about what we found. About 6 months after we published our vision of what could happen in the United States to improve maternal health, we were invited to the National Institutes of Health to talk about innovative care models. And I want to show you just one of the pieces that our team pulled out to emphasize and talk a little bit about, especially the role that doulas can play in envisioning a way of delivering care in our country that could help ameliorate some of those outcomes that I started the presentation with. Okay, so what we did is we took a hypothetical state and we modeled locations of current hospitals. So all those H's are hospitals that exist. And I believe that the data we used for this was actually from North Dakota. And then what we did is we mapped population density. So we looked to see where communities were living and where maternity services were available. And then we created a heat map that showed how far away people were from those services. So anyone who's in the green are living very close to hospitals and can typically get to maternity care relatively quickly. One exception is in this region over here where you see all of these hospitals. This is a very population dense region, and there's overcrowding in these hospitals. So you have some inability to access care as a result of overtapped resources. Then as you move out to yellow, this is a further commute to get care. Orange and then red is where it is over an hour, and in some cases over 2 or even 3 hours to get access to maternity care services. So then we asked the model to place birth centers somewhere on this map. We gave it parameters. We said it needs to be 30 to 40 minutes from a hospital that offers surgical intervention so that we would be able to get a cesarean birth. And what it shows is that birth centers were placed sometimes in urban communities that are overcrowded, but also out in these communities that are closer to rural communities. And by doing that, you get about a 40% decrease in the number of individuals who are having to travel over an hour to get access to care. When we look at this model, though, what we understand is that having birth centers or federally qualified health centers, if we can map where the ones exist and also ask where we could build them, what we know would happen is that people could get prenatal care and postpartum care in these clinics, in the federally qualified health centers or in birth centers, but many people are not going to choose to birth there. The vast majority of people giving birth in the United States, they want to give birth in a hospital because they want access to pain medication. And so we would need some way of providing continuity of care between the care that's happening out in the community for prenatal and postpartum care. Some people certainly would stay in community and give birth in birth centers, but most people would go to the hospital. And the idea was to use doulas to provide that continuity of care. So a doula could participate in the prenatal and postpartum care in community, but then also travel to the hospital with the patient for the birth. And so they would have some person who is known to them across the course of the care. There is one model that functions like this. It's called Common Sense Childbirth, and it's found in Florida. And there is these common sense or easy access clinics that are located all over Florida. People come there for prenatal visits. They're referred to the hospital because they often do not want to give birth at the birth center. Only 10% of the people who receive care there actually birth at the birth center. Their records are transferred. They give birth in the hospital, then they come back to the easy access clinic where they receive their postpartum care. And so this is modeled after that. I will say that easy access care model, the innovator of that was Time Woman of the Year a few years ago. Her name is Jenny Joseph. And in Florida, through her birth centers, they have actually eradicated preterm birth in the areas that receive her care. So not reduced it, not ameliorated it, but eradicated premature birth and low birth weight for poor Black women in Florida by providing easy access clinics and culturally matched doula care with continuity of care to the hospital for birth. This shows what would happen is if you used federally qualified health centers and birth centers as hubs, and encouraged midwives to go out into the community like we do in some of our peer nations to provide in-home prenatal and postpartum care, and then referred people to birth centers or hospitals for actual delivery. And again, doulas would be absolutely essential in this model because they allow for the patient to have some continuity of care, and it will ease that shift from community-based care to hospital-based care during the intrapartum period. And so this is what our team innovated, and we spent a lot of time thinking about how all of these spokes coming off these hubs, how helpful it would be to make sure that all those 5 different kinds of traditional health workers were available in all of those communities. So peers, health navigators, doulas, community health workers, and that this might be a way to fill some of the gaps in maternity care in the United States, which are only getting worse, it appears. I don't know if you all have been watching the news, but in the service area where our program works, there are 2 hospitals, Lebanon Hospital and Lincoln City Hospital, that are being considered for closure. And we're really concerned because that will make, especially in North Lincoln County, people more than an hour away from the nearest maternity care services. And this is in communities that already have low utilization, especially of postpartum care. Okay, and then this is to speak to what was mentioned earlier, and that is that, you know, we do have a lot of really good data just recently coming out of the United States, helping us to understand where those higher rates of maternal mortality are coming from. And what we can see is that 65% of them are actually occurring after birth. One of the ways that doulas are an untapped resource is that doulas are in the home in that postpartum period and can serve as referrers to larger systems when people are struggling. And I served on Oregon's Maternal Mortality Review Commission, and this was actually our top recommendation, that we increase access to doulas for communities who are at risk so that there's someone in the home with eyes on seeing what is happening in that postpartum period, because we also know that a majority of the deaths that are occurring in this period are preventable or possibly preventable. So what does this really mean? What this model is proposing is that we wrap care around the person rather than around the facility. So instead of encouraging people to travel or to get to faraway locations, especially rural communities that may have unreliable transportation, doulas and midwives and other kinds of community health workers who are providing care in the home are wrapping care around the person and helping to facilitate that individual getting to where they need to go. So doulas are a key way we can wrap care around the person rather than wrapping care around a facility. All right, and I want to close by just giving us a little look into the doulas themselves. So moving from this sort of big national picture now down into thinking a little bit about the actual doulas themselves, who are really making enormous impacts in their community and are some of the most inspiring people you'll meet. Many of the people that serve in our doula program do so because they experienced a sense of not belonging, not being cared for, not being seen, or disrespectful care during their own birth, or just remember their pregnancy as a time of deep fear and concern about how they were going to care for the baby they were carrying. And so they're very, very motivated to care for their community. So we had an event with the doulas where it was a research project, a multimodal ethnographic project, where we used art and poetry to elicit from doulas their experiences of providing care. And this was specifically about what it was like providing care during the early days of the pandemic, where many of the doulas in our program, because they're trained broadly as traditional health workers, in addition to being trained as doulas, many of them transitioned, especially when they weren't allowed in hospitals at the beginning of the pandemic, to being door-to-door testers for estimating rates of COVID in the community and providing information door to door in their own communities. They're incredibly effective in this way. And so they produced this beautiful artwork. The name of this exhibit was Our Eyes Take in Love. And this first piece that you're seeing here was created by 15 doulas who all drew on this individual piece and talked about the experience of being doulas. They also produced, here are some of the doulas in our program who are very, very proud of their artwork, and they took lots of selfies of themselves in front of their gorgeous artwork. And here is more of their work. And so they created these collective pieces, but then they also did individual pieces that talked about their journeys and the ways they see doulas as healing birth in their own communities. So taking their own experiences, which were potentially negative or harmful or even traumatic in some cases, and channeling that healing into healing their own communities. And I just wanted to read this collective piece of poetry that they created from this exhibit. And so what we did is we had them all talk about their experiences of providing care, and then we distilled it down into a collective piece of poetry with a line that came from each one of the doulas. So the experience of togetherness helped us release our pain, being able to heal through giving, loving. Everyone should do this. A deepening of experience and relationship, emotional journeys, tasks of emotion, love journeys that we take, all the layers that we give, our eyes take in love. I would encourage you all to go visit the Community Doula Program's website, and what you'll see is a program that we engaged with Aetna and Every Mother Counts, and these are what they call chapters. So they're short vignettes where they interviewed patients in our program, and they talked about the experience of providing care. And I think if you have any hesitation about including doulas in your program, listening to these stories about the difference that the doula made in their lives in terms of sort of the holistic care that they received are really powerful, really impactful. This is part of a program where when you go to CVS Drugs and you are buying a pregnancy test or something related to pregnancy, there's a QR code. You can scan it and you can see these vignettes about doulas, but they're really lovely. And they highlighted the Spanish-speaking doulas in our program, and you can see them in the home together, preparing traditional postpartum meals together and things like that. Just a level of care that that people really appreciated and felt was important for beginning their journey as parents. So in terms of closing reflections, the literature is very strong on the impact of doulas. We know that doulas and other perinatal traditional health workers, along with midwives, are a critical solution to our nation's maternity care crisis. Yet, even in states like Oregon, that really has some of the best legislation and supports in place to help doulas be able to practice, there's still a lot of challenges related to medical reimbursement and underutilization. So the hope is that as we move forward, doulas will become a common and highly valued part of the care team in all communities. And this slide is what doulas say about how they feel about the likelihood that they'll be moved into the system. So some of the doulas emphasize that it still feels like there are these brick walls to get over, these large hurdles that they need to be able to get over to provide care. So from the doula's perspective, all they want to do is care for the women in their community. And there are many, many hurdles to doing that. And I don't know if any of you played this game that is on the bottom here. I had this when I was a little kid. You have to take a marble and you like very, very gently sort of roll this tray and try to move the marble through this maze without having it drop into a hole. And one of the doulas in our program talked about how trying to get from meeting the client, getting connected to the client, providing the care, and getting paid feels like this a lot, that she's often falling into a hole before she actually ends up with payment. And then, of course, the unicorn is the system like the one I highlighted with that midwifery-led care, where doulas have been fully and appreciatively integrated into the care team, and they're enjoying really positive outcomes, not just for the patients, but also for the providers who are really enjoying working in a system where they have plenty of support. The providers in that hospital really strongly advocated for our doulas to be able to come back into the hospital. So they were only excluded from births for about 4 weeks during the beginning of the pandemic. And then due to the advocacy of the providers who had gotten used to working alongside them, were able to come back in almost immediately as essential parts of the care team. So can we find a way to stay with the trouble? So it takes time to bring in new members of a care team. But I love this picture because you can see the doula holding her client's hand as that baby has just been born. And whenever I see this is a client of mine, whenever I go to her house, she has this picture framed on the wall, and she feels like all the hands that are on her show kind of the ideal of how people want to welcome their baby into the world, feeling like that baby is coming into the world surrounded with a healthy community and loving care. And I'm going to end with this in hopes that pictures really do speak 1,000 words. This is Isla Rose's mural. She's a Eugene artist. And I look at this on the days when I feel frustrated or challenged by working in the systems that we work in. What it shows is a fat, chubby, healthy baby, not preterm, not low birth weight, cradled in a loving community, surrounded by a healthy ecosystem. And I think that this is what we all want for our families, and doulas are one way to get there. So thanks to all the funders, and I'm happy to take questions.
Thank you so much, Dr. Cheney. I always appreciate how you are able to connect the big picture ideas with keeping our pregnant people at the forefront of the conversation. So thank you so much. Again, I'm Christina Clay, and it's freestyle time. So thank you all for your engagement and questions. I've been monitoring the questions in the chat, and it's time to get them answered. It's not too late to ask them, so if anything's coming to mind, please pop them in the chat now. But to get started, Dr. Cheney, along the lines of the last comment you made, what do you think are the biggest areas of resistance that have been in place around expanding doula utilization, and what can we do to address that?
Yeah, so from my perspective, the most challenging thing is figuring out how to navigate reimbursement. I'm thinking about how to say it in a way that recognizes that it is difficult to be the first one to do this, right? There are not other models to figure out how to reimburse quickly and efficiently and fairly. The other thing is we recognize we need to be really great stewards, very thoughtful stewards of precious Medicaid dollars. But it is very, very difficult to be able to keep people in this work if they're not reimbursed quickly, efficiently, and at a rate that allows them to have a living wage. Oregon started out offering doulas $75 for a course of care, then it went to $350, then it went to $1,500. And I understand that there's a lot of thought now going into raising that. We're kind of sandwiched between California and Washington, where they're reimbursing at about double that rate. And I think Oregon is trying hard to catch up. So we really started out first, but then I think people learned from some of the things that we were trying to navigate and have been able to sort of correct those things right out of the gate. So we do need to build those infrastructures to support doulas. We surveyed all the doulas in our program and said, okay, the program's up and running. There's 165 of you. We have a referral system in place. How many of you would just like to take over billing and referrals yourself and kind of ease out of the hub model? And 100% of them said they would leave doula work if they didn't have a hub to manage all of the things like billing. Doulas want to be doulas. They don't want to be Medicaid billers. And so I feel like that is the most challenging thing that we face. And I really look forward to the day that we can get that streamlined so that there is a much shorter turnaround time between delivery of care and people being able to be reimbursed. And part of that might be that our state needs to look at effective ways to fund hubs, which I know is happening right now. Our hub is funded by nonstop grant writing, and that is probably not sustainable. We need, if we want doulas, we're going to have to build the infrastructures to support them.
Fantastic. Thank you for that response. The next question, as a doula, I'm wondering if Care Oregon can comment on any advocacy happening to increase consistency between CCOs. Some CCOs require prior authorizations and contracting, which creates even more barriers to doulas being able to bill for clients. Is there advocacy happening to simplify this? And Missy, you may also be aware of what's happening in this space as well.
Mm-hmm.
I'll start with Meg.
Yeah, I mean, I think that challenge is something that we as a CCO are trying to iron out and advocate to ameliorate. And I think it takes a lot of systems and communication. I think the CCO can play a really large role as long as there's partnership with doula hubs and doula communities, and also the systems that they're interfacing with to get access to people who want to utilize their services, but also the systems that sort of surround them and the reimbursement process. I think because of the data that Joe shared and the newness of it, I think there's a lot of factors, and I think it has to do with communication pathways and bidirectional communication. But I'd love to hear from Dr. Cheney on that as well.
What I see day in and day out is the Megs and the Leonas of the world working so hard to make doulas accessible. I think there's nonstop, all day long advocacy happening in all of the CCOs I work with and in most of the hospitals and birth centers and home birth practices that our doulas serve. To me, it feels much more systemic, like much more, moving away from individuals and looking up at some of the larger challenges that we're facing as a society right now in terms of having such a large country and having such a high percentage of our population having births that are paid for by Medicaid. It's an enormous task to manage that. And I work in a university where we joke that like policy moves at like a glacial pace. I think that is really also true in healthcare, that no matter how incredible the people are and their intentions are, there is a frustration that comes with the speed of change, and it can feel very, very, very slow. So I see lots of advocacy, lots of heartfelt, passionate advocacy, and still very slow change, very slow movement. And that's why we have adopted this phrase, staying with the trouble. I didn't credit it, but this comes from Donna Haraway, who said that, when you're facing a really sticky, difficult social problem like we have in our country around inequities and birth outcomes, many people give up. You start walking down that road of trying to do repair, and it takes so long that you're like, I'm out. This is too frustrating. And that what we have to do is stay with the trouble, keep trying and move a little bit at a time. And I think we are doing that in Oregon, but I have a deep appreciation for all the doulas and clients who are out there pregnant right now who are like, why is this so hard? It is hard to move a mountain. It just is.
Pebble by pebble.
Pebble by pebble.
All right, the next question, maybe a question for Dr. Black, or again, Dr. Cheney, if you have thoughts here. Is there a goal for the number of Care Oregon members or Medicaid members in general that we should be seeing receiving doula care, a metric or a measure?
Dr. Black, do you know the answer to that? Besides as many as possible?
To the best of my knowledge, we do not have a measure or a metric around the number of the proportion of doula assisted births.
I would say in the advocacy realm, we say everyone who wants one gets one. And I think part of it is we don't know exactly how many people want one. We do, of course, have people who don't want a doula. We have people who decline services, who just don't want another person at the birth. But I'm not sure that we have a good sense of what that number would be. But we say it's everyone who wants one.
I think that's a perfect answer. Next question. How can we briefly explain to a client what a doula does and why it would make sense to refer a patient to one? What is a one to two sentence elevator speech I can give to my patient about why this is important?
Okay, well, you all just listen to me talk for 40 minutes. You know that I don't have an elevator speech, right? I have 40 minutes of why you should do this, or 50 minutes why you should do this. I will say that what I usually emphasize is that continuity of care, the importance of having your go-to person. There's something that is so comforting about that. And then the other piece that I always share is that the doula doesn't displace the partner or the mom or the friend, whoever else is there. What their job is to assist whatever the team is to get the best possible outcome. And the doula is really caring for the whole birthing team. And I think that is very helpful for people. They want to make sure that their partner is not going to be displaced.
As a community midwife myself, one of the lines I often use is the doula supports the support person in being a better support person.
Yes,
So,
yes, love it.
Next question for you, Dr. Cheney. With the current political climate, is there fear we may lose this benefit in the Medicaid space? I would also love to hear if Dr. Okeefe or Meg, if you have thoughts in this. We'll start with Dr. Cheney.
Yes, we live in fear of this going away. I will say I mostly feel hope that it won't. I tend to be a glass half full kind of person. I mean, half full, optimistic person. I'm involved in a project with the Institutes for Medicaid Innovation right now, where there are teams from all over the country that are coming together to talk about how we problem solve through this particular scenario that we find ourselves in now, to make sure that we preserve options and center people who are growing up, the next generation, of our nation, through the next period of time here. And I get a lot of hope out of being there. I think there are really so many people at all levels who kind of understand that we have to invest in our communities right from the start if we want to have a healthy nation and healthy communities. And we are, of course, very buffered in Oregon. I feel very hopeful that we will weather this storm together.
I think I would add too that the uptick in utilization provides data that makes a case, right? Bigger populations that are accessing doula supports, and then being able to show those outcomes and make a stronger case why the bottom line is impacted when we have healthier communities and lower, acute care sort of utilization, and the things that Joe sort of shared. If we can move that trajectory, and the folks that are at the table who are working with patients in OB settings and other primary care settings, let's get doulas involved and show why we need to keep them around. So that's kind of a call to action and how I would respond to that question. Don't know if Leona wants to add anything.
I think those were perfect responses and exactly what goes through my head. Yes, there is concern. And in Oregon, our top leadership are absolutely on the same page of wanting to provide care for everyone, acknowledging the importance of perinatal and early childhood care. And just thinking back on the previous question as well, that change occurs in such a slow way at the glacial speed that Dr. Cheney mentioned. And I think part of that is because there are cultural changes. It's really easy to see all of this as just logistical rule changes, but really behind that is a lot of culture changing and people acknowledging how they've thought of their identities and being willing to change that a bit in order to best serve our populations. And cultural changes are really slow. And each of our stories are really important to changing those cultures. And so that's why this is not just a legislative thing. It's not just a state or CCO level thing. It is at the individual level of everyone sharing their stories of, hey, OHP is Medicaid, and Medicaid offers doula services. We cover doula services, and this is my story with a doula, or this is how I've seen doulas impact care in a positive way. And those are the ripple effects that end up changing culture. So I think that's what I would add to the question. It's a great question.
Thank you, Dr. Okeefe. That wraps up our Q&A. Meg, I'll bump it out to you to close out.
I would love for everyone to be able to have easy access to a doula. And if there are questions about how to connect with doulas from your practice in your area, there are regional supports connected to the CCOs. So in Portland Metro, there is an email address for our traditional health worker liaison. Jackson Care Connect and also Columbia Pacific have regional focused traditional health worker liaisons that interface with the doula network and with the clinical care teams, and can also help with billing questions that come up and other things that are related to doula services to, like Dr. Cheney said, try to get that reimbursement happening and get those connections made in a timely manner. So we encourage you all to connect in and make a case for why doulas can get involved and connect patients where possible. And with that, I'm going to pass it over to Leona Okeefe for a closing statement. Please remember to respond to the email, the evaluation survey, in order to get those continuing education credits if you'd like them.
Yeah, thanks, Meg. I think I would just encourage all of us to walk away from this with a tangible thing that we can each do in our role. So for me, I've already written this down. I'm gonna go learn about that program in Florida that has literally eliminated preterm birth. I am like stunned by that. So I encourage you, before you head back into your busy day, write down something tangible that you see you can do in your space, whether it's sharing your story, advocating somewhere, or continuing to do the best you can in your daily job. Like Meg said, reach out to us if you have other questions, or if you have specific suggestions on how to improve perinatal care, including through partnerships with doulas. Feel free to reach out to us. And a huge thank you again to Dr. Joe Black and Dr. Missy Cheney for all the work that you do and for taking the time to share with us. And thank you to our attendees for what you do in the community. I love what Dr. Cheney said, no one is at risk of receiving too much love and care. So as you provide that love and care to the patients and clients and community in your circle, remember that you have a team around you as well. So reach out, ask for help, ask for guidance if you need it. And remember that you have that community supporting you as you support the patients in your circle. So thank you, and we hope you all have a lovely day.